Welcome to part one of our three-part series where we dive deep with leading experts in the field of medicine. So get ready for insightful conversations. Let's get started. Hello and welcome to the EMJ podcast with me, your host, Dr. Jonathan Sackier. Today we have the pleasure of being joined by Dr. Peder Myhre, professor at the Jebsen Center for Cardiac Biomarkers at the University of Oslo and senior consultant at Oslo Hospital, the University Hospital, the Rikshospitalet. I'm sure I've mispronounced it, but there you go. I do my best. Peder is a leading expert in heart failure biomarkers and cardiovascular imaging, and also serves as deputy head of the Norwegian Heart Association's Heart Failure Working Group. With an impressive research portfolio of over 110 academic papers, more than half as first or last author, including 40 papers in the past 2 years alone. I wonder when he sleeps. He's at the forefront of advances in cardiology. Outside of work, Peder has been known to embrace Norway's great outdoors as a cross-country skier. I like downhill skiing. I've tried cross-country skiing, and after 5 minutes, I'm utterly exhausted. So I great respect. I hope you enjoy the conversation with Dr. Peder Myhre. So let's get into it. Welcome, Peder Myhre. Lovely to have you here.
Thank you so much, Jonathan. It's such a pleasure to be here, and I look forward to discussing with you today.
Fantastic. So I mentioned your cross-country skiing. Respect. I have tried it. Damn hard. And I know that you posted on, I think the way you said is posted on X, formerly known as Twitter, that your love of cross-country skiing and how people in Oslo ski to work. That's one heck of a way to commute. There was a study published in Circulation, the premier journal, showing that male endurance skiers had a higher incidence of bradycardia and pacemaker implantations compared to non-skiers without affecting mortality risk. I can kind of get the bradycardia bit, but the pacemaker thing was a bit of a surprise. Can you elucidate what these mean?
So you're absolutely right. So cross-country skiing is the major sport here in Norway, and living in the capital like Oslo, where you have access to ski slopes just 10 minutes from the city center, is quite unique. And I think it's the only capital in the world with that kind of resources. And cross-country skiing is a fantastic sport to exercise and your heart also. So when you do cross-country skiing, your heart will also get the endurance exercise, and you get the bradycardia you see from being in good shape, basically. And I think it's simply that what was shown in the Circulation paper. That was from Sweden, actually, from the big Vasaloppet, where they saw that there was quite an increased risk of developing bradycardia and also having pacemaker implantations. But I think it's important to also highlight that those participants in the study still had a much higher survival or longer expected life expectancy compared to the general Swedish population. So there's no doubt that there's health benefit from exercising, and we see that in cross-country skiing as well.
Yeah, absolutely. Well, maybe I'll give it another go, but I was skiing recently, and I thought I'd give it a go, and then was chatting to some people and saw how exhausted they looked. But anyway, so you were recently awarded a very prestigious prize, the Blix Family Fund Award, for your research on cardiovascular disease, particularly heart failure, which is, kudos on your achievement. The prize was 1 million Norwegian kroner, which not only recognizes scientific excellence, but also supports further advancements in the field. Tell us about your research focus and how you see this award shaping your work going forwards.
Yeah, thank you, Jonathan. So, my research is primarily focused on heart failure. And what I think is important is to recognize that heart failure is simply a deadly disease with a prognosis that is much worse than most cancers. And unfortunately, we do not detect these patients, right? There's about 10% of individuals older than 70 years have heart failure. However, less than half, even only a third, are actually diagnosed with heart failure. So that's one part of it, is to improve heart failure diagnosis and recognize heart failure. And a key to do that is to have biomarkers available and measure biomarkers, because for GPs who are not familiar with echocardiography or ultrasound of the heart, the biomarkers is their main tool. And the second part, and that's more specifically what this funding will go to, is to see if we can improve heart failure management after they are diagnosed. So what happens today is that patients come to a heart failure clinic at the hospitals, but there's a lot of patients waiting to get this follow-up, and they're not able to take patients in as quickly as recommended. So what we're testing now in the trial is to see if we actually can move the follow-up and the treatment up titration of the medications to their homes, and do that by digital follow-up, and do it by measuring blood pressure, even measuring biomarkers at home in their living rooms compared to traveling to the hospital. And I think, for Norway and many other remote countries which are less densely populated, it's even more important, because it takes a lot of effort to get these elderly people to the hospital, with efforts from relatives. And so I think moving some of the care into the patient's homes is important, and that's what I'm looking forward to using this award for.
Yeah, it's interesting. I've talked to various other folks on the this podcast about just that, those two elements. Number one, using digital monitoring. We tend to bring people back, don't we, for regular appointments,
Yeah.
and they come in and they have to travel there, they have to consume carbon fuels to get there, they have to sit around ugly, drafty waiting rooms with other sick people. And, invariably the clinic runs late and they come in and the doctor says, "How are you?" Says, "I'm fine." What the heck was the purpose of that?
And nothing is done, right?
Nothing is
Yeah.
done. It's terrible for the patient. It's a waste of their medical staff's
Yeah.
time. It's bad for the environment. So, congratulations on rolling out these things, because I would have thought that like chronic inflammatory diseases like rheumatoid arthritis, psoriasis, um, heart failure, and diabetes, these are the
And COPD.
COPD. There you go, can be well managed. The other thing that I'd like to, and we're going to dig into this, but I'd like your overall comment. You mentioned 10% of people over 70 have heart failure, and only a third are diagnosed, right?
Mm-hmm.
So another cardiologist was telling me that we have the damage of hypertension going on for 15 years before someone notices a raised blood pressure, and we need better biomarkers to suggest something bad is happening.
Mm-hmm.
Can you foresee a day where we will be diagnosing your risk of heart failure in your 30s or your 40s before things start going pear-shaped?
That's a great question. And heart failure is actually not that hard to predict, because the risk factors, we're very well aware of the risk factors. It's hypertension, it's obesity, it's diabetes, it's having a diet rich of salt, etc. So if we're able to identify these risk factors and treat them earlier in life, we will prevent heart failure. And in addition to that, we do have the biomarkers again. And I think we're going to come back to this, but there is this specific biomarker called the natriuretic peptides, or BNP, which I think many are familiar with, which is a very good biomarker, not only to diagnose heart failure, but also to predict the risk of developing heart failure. So I think that is key also in the identification of risk.
Yeah. The other thing that the other element, if your specialty is to learn from others, is to get people to buy into the concept that being obese, smoking, having diabetes, having the wrong kind of diet, not exercising, this is what you're doing now. This is what it's going to look like.
Mm-hmm.
And there is a bright line between the two. And in medicine, I mean, I do a lot of colorectal stuff, and educating people the need to have a screening colonoscopy, finding a polyp and removing it, or you can have a colostomy and a shortened lifespan. Which do you want? You know,
the problem is that these things it develop later in life, and at a younger age, when they're actually exposed to these risk factors, they don't really pay attention to the risk associated with it, because that's having a high blood pressure or having a bad diet, obesity is not a concern when you're 30, but it will hit you when you're 60 or 70.
Yeah, absolutely right. Well, maybe we need to get more clinical psychologists involved.
Yeah.
So that wraps up part 1 of our series. Thanks for listening. Be sure to join us for part 2, where we continue the conversation and uncover even more valuable insights.